everyone. Welcome to today's Better Care Playbook webinar on the Transitions Clinic Network, made possible through the support of the Seven Foundation Collaborative. My name is Kelsey Breichman, and I'm a Senior Program Officer at the Center for Healthcare Strategies. Next slide, please. Before we get started, I'd like to go over a few logistics. To eliminate background noise, audio lines are being muted for today's event. There will be a moderated question and answer session following today's presentation. You may submit a question online anytime by clicking the Q&A icon located at the bottom of your screen, as shown by the instructions on the slide. Today's event will be recorded and shared publicly on bettercareplaybook.org. At the end of the webinar, we ask you please complete a brief online evaluation that will pop up on your screen. Your feedback is very important to us. Next slide, please. Next. And here's our brief agenda for today. After I go over some of these housekeeping items, I'll introduce our guest speakers, and then I will turn it over to them to provide key elements and implementation lessons from the Transitions Clinic Network. We will then have 20 minutes for moderated Q&A at the end of the session. Next slide. For those of you who may not be familiar, the Playbook is an online resource center for evidence-based and promising practices to improve care for people with complex health and social needs. Every month, the Playbook summarizes new journal articles, evaluations, and implementation tools. We also develop resources like this webinar designed to help translate evidence into practice. Next slide. The Playbook is coordinated by CHCS through support from 7 leading national healthcare foundations: Arnold Ventures, the Commonwealth Fund, the John A. Hartford Foundation, Millbank Memorial Fund, Pearson Center on Healthcare, the Robert Wood Johnson Foundation, and SCAN Foundation. Next slide. Improving care for individuals released from incarceration and returning to their communities is an important topic because these individuals frequently have complex medical, behavioral health, and social needs that aren't adequately addressed. People with a history of incarceration face health disparities across a wide range of physical, behavioral health conditions and have a higher risk of death compared to the general population. Supporting the well-being of this population is essential to advancing racial health equity, as structural racism has caused significant racial and ethnic disparities in incarceration rates. At the same time, the policy environment is beginning to shift and open up more opportunities to support new care delivery approaches like the ones we will discuss today. Next slide. So with that context, I'm pleased to introduce our 4 presenters who will describe the Transitions Clinic Network model for transforming primary care to provide patient-centered and culturally appropriate care for individuals with a history of incarceration. Shira Shavit is a clinical professor of family and community medicine at the University of California in San Francisco and the executive director of the Transitions Clinic Network. For nearly 2 decades, Dr. Shavit has been redefining national best practices for care for chronically ill individuals and communities impacted by mass incarceration. Under her leadership, the TCN model grew from the flagship program in San Francisco, where she continues to treat patients, to 48 health systems nationwide. I'm also excited to welcome Tommy Green, currently the lead community health worker for North Carolina formerly incarcerated transition program at the Orange County Health Department. Starting at age 22, he served 11 years and 18 months in prison for his part in an armed robbery. Once released, and after working a variety of other jobs, he was eventually offered a CHW role. Tommy is now also an adjunct instructor for the UNC Family Medicine and serves in leadership positions at Success While in Transition and Wounded Healers, organizations supporting other formerly incarcerated individuals in transitioning back to society. We also have James Mackey, the Transitions Clinic Network Program Manager and Coordinator of Care Management with Community Medical Centers in Stockton, California. James has developed the TCN program at CMC, where they have helped over 400 formerly incarcerated men and women navigate the health system and recognize themselves as part of the larger community. In his role, James hires and supervises community health workers and case managers who understand the particular needs of returning community members. And last, but certainly not least, I welcome Lisa Puglisi, an internist and addiction medicine specialist. Her clinical care, education, and research efforts are primarily focused on improving the health and well-being of people who have been impacted by mass incarceration. She directs a transitions clinic in New Haven and a statewide network of similar programs. She directs interdisciplinary teams of physicians, mid-level providers, community health workers, research personnel, and legal colleagues to improve care for those who have been incarcerated. So, welcome everyone. Thank you for joining us. And with that, I'm going to pass it to Shira to kick off the TCN presentations.
Thank you so much, Kelsey. And I want to say thank you to CHCS for having us here today. We're just so excited to be here. This looks like a fantastic audience, and we're just really excited to share with you some of our work and then hopefully have some time for Q&A and have a lively discussion over Zoom. So as you all heard, I'm Shira Shavit. I'm a family physician and faculty at the University of California in San Francisco and the executive director of the Transitions Clinic Network. You can see a picture here of Southeast Health Center, which is our flagship site and the federally qualified health center where I still see patients who are coming home from incarceration alongside my colleagues who are our community health workers here in San Francisco. So we're real excited to talk about this work, but let's go to the next slide. We want to hear first who's joined us today. So we're going to have a little poll and know who's in the room with us so we can get a better sense of who we're talking to. So please go ahead and answer the poll. What type of organization do you work in? So I'll just give people a couple seconds to answer that. Okay, wonderful. All right, interesting split of different organizations. So that's fantastic, really helpful to see. So we have a lot of providers here today, folks from local, state, or federal government and community-based organizations, some researchers and others. So good, we look forward to hearing from all of you as we move forward with this presentation. So go ahead to the next slide. And there is a Q&A function and a chat function, so please, feel free to ask lots of questions. We really love the dialogue with people who are interested in this work. It's really important to us, not only to share information, but to hear from you all and kind of hopefully spur some conversation as best we can in this Zoom room today. So as you all heard, I'm the executive director of the Transitions Clinic Network. We're a national nonprofit organization that provides capacity building and support to health systems that are looking to improve health equity for communities that are impacted by mass incarceration. And we started a program in San Francisco. You're going to hear a little bit more about it from me today. In Bayview Hunters Point, which is a community disproportionately impacted by mass incarceration, and have then disseminated this model of care, not just in our community in San Francisco and in California, but nationally. And we've worked with 48 primary care clinics in 14 states and Puerto Rico to implement this model of care. Our work is not just centered around transforming systems, but also addressing policies that impact the health and well-being of the communities we serve, along with implementing and evaluating this work and thinking about what research is necessary to continue to improve the care for people impacted by mass incarceration. Next slide. And so today I'm joined by my colleagues. As you see, we've done this work nationwide, and you're going to hear from my amazing colleagues today about some of their work locally in their own organizations. But before we do that, I just want to spend a little bit of time kind of level setting. I would imagine many of you know this already, but I think it's really important to, recognize that mass incarceration is a series of policies and laws over the last 50 years that has had devastating impacts on communities in our country, and specifically communities of color, the Black community, and poor communities. And many of you know this, but Black men, for instance, have a 1 in 3 lifetime chance of incarceration as compared to white men, which is 1 in 17, or Latino men, 1 in 6. Women of color also experience these disproportionate rates of incarceration. So when we think of mass incarceration, we know that this is a form of systemic racism in our country and really has significant health impacts on communities. And so in thinking about health equity for these populations, it's really about how do we, address this devastating impacts of systemic racism in our country. Next slide. And that, we have increased the number of people behind bars and on community supervision, probation, and parole in our communities over the last 50 years. It's been astronomical. And we've put very vulnerable people into the carceral system. And you heard Kelsey talking about how people who are in our carceral settings and impacted by these systems have much higher rates of chronic medical conditions, behavioral health conditions like substance use disorder and mental health. And yet these are environments that are not conducive to healing. They're traumatizing, and they're places where people often develop new conditions or get sicker. And I think this picture speaks volumes. This is one we've used for years to talk about the negative health impacts of incarceration. But when I see this now, I can't help but think about the last few years with COVID. And we know that people behind bars were exposed to COVID at times 5 times the rate as the general population. And it's a perfect example about how these systems and environments don't necessarily foster healing and oftentimes can exacerbate poor health. Next slide. And that when people are inside, even though they have a constitutional right to healthcare inside, that care may be limited. It may not meet the needs of their substance use disorder or mental health treatment. It may not meet the needs of their medical conditions that people, we know that many of our systems provide inadequate care. In California, where I'm from, our state is still under federal receivership because we had 1 person dying every week from preventable causes in our state. And this actually is a picture of individuals in group therapy in our state prison system. So you can see that, what is provided may be limited. It may not meet people's needs. And what happens inside really impacts their desire to access care in the community. So next slide, please. And then, pretty much the majority of people who are incarcerated, 95%, return home to the community. And we know that that period of reentry actually is quite dangerous. So even though people may not be getting good care inside, that transition to the community actually puts them at higher risk. Next slide, please. And this is a seminal article that many of you are probably familiar with, but that really demonstrated the increased risk of death in that transition home from prison. People are 12 times more likely to die in the first 2 weeks post-release. And for me, this really had a significant impact on me as a healthcare provider. When I first read this article, seeing the leading causes of death being drug overdose, cardiovascular disease, suicide, and cancer. These are things that I address in the primary care setting. This is my bread and butter. This is what I do every day. And to see that as a healthcare provider, I could do more to address this risk of people in my community was a real call to action for me personally. So I think it's important to recognize when people are coming to our health systems from the incarcerated setting, it's a very risky time, and that we as healthcare providers have a real duty to step up and help people during this very vulnerable time. Next slide. And that, a lot of this is due to the multiple health-related reentry challenges people have when they come back to the community. Most of these systems are not well connected. There may be little discharge planning. Health records may not be shared. People come out with no or very little amounts of medication. They may or may not have insurance. That insurance may have lapsed. And then also people have to address all of their basic needs at one time. So when we think about the social determinants of health, finding housing, getting a job, getting food on the table, reconnecting with family, all of those things are real challenges for people that are kind of all these needs up in the air at the same time, in addition to having to meet their health needs. And for people who are coming out of incarceration, they may face collateral consequences of incarceration, which are laws and policies that continue to impact in that period post-release. We also know that people face discrimination and stigma in the community because of their history of incarceration. And there are many studies showing that in our health systems, people face discrimination because of their history of incarceration. So there was actually a study that showed that when people self-identify as coming out of prison, they're half as likely to get a primary care appointment in that clinic. So it's really important to recognize that those challenges, the community may face many challenges in getting access to care. Next slide. And those collateral consequences of incarceration, I mentioned, are numerous. These are additional barriers people face when they come out. They've been documented, and there are over 44,000 collateral consequences of conviction. So some of the biggest ones are around employment. And when people come out, it's very difficult to get a job with a history of a criminal record. And that then has, kind of an additional effect on people's ability to integrate into the community, on their livelihood, their ability to support themselves and their family, and has had a devastating impact across multiple generations now that this has been going on for the last 50 years. So I think it's really important when we're thinking about supporting people coming home from incarceration. I know for us in the health setting, we're all trying to address the social determinants of health, but we have to also recognize there's this additional layer on top of the needs that people have that make it even harder for them to meet their basic needs. So let's go on to the next slide. So I think, that's just a very quick overview of some of the challenges that people who have health needs who are coming home from incarceration may face. I think it's important to, it's easy to kind of talk about our system of mass incarceration and how it's impacted health. I think it's easy to look at that system and see some of the negative aspects, and then kind of those disruptions in care back to the community. But I think the other piece we really need to examine is our own health systems, and what role do we play, and how do we transform our own system to better improve care for people coming out. And when we started this work in 2006, interestingly, in San Francisco, we had universal coverage. This was pre-ACA. We didn't have, not everybody had Medicaid at that time, but our city and county was providing coverage for everyone. And yet we were still seeing people hospitalized unnecessarily post-release for reasons that seemed preventable. So an example is somebody on dialysis coming out of prison who didn't get linked to care in the community and had no choice but to go to the emergency room and end up getting admitted for their dialysis. So it became very clear that our current systems weren't working well, and we really wanted to embark on understanding better what were ways we could transform our own systems to better meet the needs of people coming home. Next slide. And so this process, was started in 2006 in our community. As I mentioned, the clinic I work in is Southeast Health Center. It's in the historically Black neighborhood in Bayview Hunters Point. And so this is probably the most important piece I'm going to tell you through our entire presentation, which was we reached out to our own community, engaged individuals who were impacted by the system, community advocates impacted by the system, to understand what do we need to do to transform our systems to meet the needs of the community? And really kind of a series of deep listening sessions to better understand the challenges from the perspective of the communities we serve. And so what we heard was, first of all, you need to include people impacted by these systems in the design, implementation, and evaluation of all your programs. So it's not just enough to have one conversation. That conversation needs to be ongoing in the design and the implementation. So you need to have staff who have experienced incarceration as part of your teams ongoing to support patients coming out, but to continually improve what you do and to drive this work forward, and not just in the provision of care, but in the evaluation as well. And then what we also heard from the community was that it was important to incorporate a broad definition of health and well-being. And in 2006, primary care was very focused just on physical health. We did not have a lot of behavioral health integration. We weren't thinking of things from a trauma-informed lens. And we really learned that, people are not just their diabetes, but their health and well-being is so much more. And it's about connections with the community. It's about addressing their full needs, including all of their reentry needs or social determinants of health. That we had to adapt our systems to be patient-centered, that we can't expect people to just come to our systems and adapt to our systems. We need to understand what they need and transform what we do to meet their needs, which is really what health equity is all about. That we want to give more power to patients, to the community health workers community in our systems, and that we want to transform systems in our own community and get people to come to our existing community health systems, but not create something, a separate system for people coming out of incarceration. So for example, people want to be sitting in the waiting room with their families, with their partners. They want to be treated just like everyone else. They don't want to be seen in a separate clinic for people impacted by the system. So when we say transitions clinics, we really mean programs within existing health systems that meet the needs of people coming home, not a separate system. We don't want to continue to further, other people or separate them from the community. And then lastly, one of the really important pieces is ensure that we're not inadvertently replicating the punitive aspects of the carceral system, and that when people come and see their provider, they know that it's confidential. They know that what they share will be protected and that they will be cared for and that it's not a punitive environment. And so it was very clear at this point that, the community health worker piece was so critical to really transforming what we do in our health systems. Next slide. So really this idea of our model is taking existing primary care systems. If you could go back one more for me, that would be great. One more, there you go, thanks. I know sometimes those buttons get real touchy. So you take an existing primary care clinic and transform the practices to meet the needs of the community. Number one, by integrating community health workers with lived experience of incarceration into teams, into the primary care team. And they play a very important role in those teams, helping people navigate both the health and social determinants of health. And you're going to hear more from Tommy Green all about the very critical role of the community health workers, and also transforming systems to integrate mental health services, substance use disorder treatment, other types of primary care like addressing HIV and sexually transmitted infections, hepatitis C, along with having community advisory boards with ongoing input into that system and thinking about all the ways we transform what we do. And sometimes it's really small things like, many clinics have a 15-minute late policy. And if you're coming out of incarceration and you don't know your way around the community, it's very likely you might be late arriving to your appointment. And then if you're turned away because you're late, that feels very punitive. So in our program, we don't turn people away. We don't use that 15-minute leave policy. We've really looked more clearly at what we do to transform, even on the small levels, to meet needs for people coming home. Then we work really closely with other systems that people interface with when they're coming home, like the criminal legal system, probation and parole. Some of our sites do in-reach and meet with people pre-release or outreach, right, when people first come out of those systems. We also work across other systems like reentry service providers and build close relationships with other reentry service providers to ensure that we can meet our patients' needs around the social determinants of health. And we build stronger relationships with our community networks to ensure that people have that community support in coming home. And then along with other health systems like the behavioral health system, higher levels of care in that system, housing systems, tertiary care systems, and public health systems. So this is really, in essence, our model is building up what we do in our own practice, and then really building these strong relationships across all the other systems in our community to ensure that all of these needs are met for the patients that we serve. Next slide. And I'm going to pass this over to Tommy Green, who is going to talk more about the role of the community health worker in the TCN model.
Thank you, Shara, and hello again, everybody. Again, I'm Tommy Green, the lead community health worker for the NC FIT program, which stands for Formerly Incarcerated Transition Program. And I'm also the FIT coordinator for Orange County. And I'm going to speak with you today about the vital role of the CHW in the TCN model. First, I just want to say, traditionally, medical systems have historically not treated impacted communities well, from poor access to care for impoverished communities to substandard care inside of prisons to no continuity of care post-incarceration. And then it's almost like a vicious cycle because the majority of the people released are released back into impoverished situations. So it's almost back to ground zero with dealing with access to care for impoverished communities, let alone the stigma and racism embedded in America's history regarding marginalized populations and the carceral system. Also taking into consideration all that mixed in with the fact these people have traditionally just been mistreated, and a lot of them just don't trust the medical system in general, period. For these reasons, CHWs are like cultural ambassadors. Some of our biggest responsibilities are, in my opinion, liaisons for the population that we serve, and also a voice for the voiceless. Next slide, please. That's where CHWs with lived experience come into play on bridging the gap. For example, like when you're incarcerated, right? For example, when you're incarcerated, one of the first things you do when you hit a new yard is you seek out maybe someone from your hometown, someone you may have knew from the streets, and they kind of act as a guide. They kind of can tell you like which sergeants or which officers are cool, which sergeants or which officers are not cool, what time is usually chow call, different things like that. And I can make that more relevant to my collegiate folks on the call that have never had with no history of incarceration. Picture when you first went to college, and you know how it is when you're in a foreign land, you're in a foreign school, so on and so forth, and you bump into someone from your hometown. Naturally, you're gonna lean to their guidance. Your shoulders are gonna kind of drop a little bit. You're gonna be a little bit more relaxed. So you're gonna take their advice. You're gonna find out, where the mess hall is, where the student union is, all the above from that friend. And that's kind of like what the TCN model is about. The community health workers from the same community, serving the community they're from, and the population of people that have the same commonalities, formerly incarcerated, so on and so forth. I can't tell you how many times, like I've been in this job now since 2018. I've served almost 100 clients, and I could say 100% of the time, every single time I tell one of my clients that I have a history of incarceration, again, you see that shoulder, you see those shoulders drop again. You see them relax. You see them start receiving the information that I'm trying to give them a little bit better. And also I bridge that gap between the patient and the doctor. Because again, traditionally, these people had a hard time when it comes to medical, especially inside. I can tell you from experience, I'm a person that, I don't have anything, I don't have any medical issues that I needed to be taken care of while I was inside. But I did have small incidents where I might have injured myself on a basketball court or something, had to go get stitches, so on and so forth. And everybody gets sick, catch the cold, might even catch the flu or something sometimes. And so I've had the experience of actually going in and feeling like, you know, I'm not getting the best care, or I'm only the person that I'm seeing right now is really only just here for the check, and they really have no compassion or no sympathy for the person that they're serving. Can you go to the next slide, please? Again, one of the things about meeting patients where they are and bridging the gap, it makes a difference when you have a person that'll actually come out to your community, come to your house if you need transportation. Because again, one of the barriers to healthcare for this population of people is access and/or transportation. So when you have someone that'll come pick you up, take you to the clinic, sit in if you want to, because some clients are so uncomfortable, especially ones that are just recently released, and this is one of their first or second time seeing an actual doctor. Sometimes they even ask us to come in the room with them just so they'll have that brother or that sister in arms with them while they are getting their service or whatever. I can give you an example of a couple of clients of mine. One guy, he had severe mental health issues, severe trust issues, all the above, paranoid schizophrenic, and he was like textbook and everything that I just named, right? And so when he first started coming in, you know, I did him like I do all my clients and all the people I meet. What I like to do is introduce myself first, let you get to know a little bit about me, and then I'll tell you that I'm formerly incarcerated. And honestly, I do that because of some of the stigma attached. I want people to meet the person first, and then I'll reveal my history or whatever. So with this particular client, I did the same thing, and it was like day and night. Like when he first came in, you know, he had met me because he was referred to the program. And when he first came in, again, all he knew was this guy named Tommy Green, that's a community health worker, not even sure what that even means. And that this guy was going to meet him at his medical appointment. So first time in, you know, I'm sitting there with the doctor, and I could kind of tell that he's looking around, and he's going looking from me to the doctor, and he's looking like a caged animal. And then when the doctor stepped out for a minute, that's when I had the conversation with him, like, look, man, you know, I've been exactly where you've been. And he kind of frowned, like, what do you mean? I said, I'm what they call formerly incarcerated. I'm sorry, the correct term was justice involved, was what I used with him. But I said, I'm what they call justice involved, meaning I have a history of incarceration. As a matter of fact, I told him the length of time I was in there, which was almost 12 years. So this guy, he had been in half the time as me. So he automatically respected where I was at in life, what kind of information I was giving him, and he automatically trusted that I had his best interest in heart. And so by him feeling like I had his best interest in heart, I was able to bridge that gap without doctor. Now he knows the doctor has his best interest in heart, I have his best interest in heart, and everything that we both told him and talked to him about his medical care, he started listening and started receiving it. Now this guy, it's been almost 3 years since he's been in the program, and this guy has been able to keep a job. And I'll be always honest, he struggles, you know, he's lost a few here and there, but he always ends up back on his feet. He's kept he's been in his apartment now for a little bit over a year. He's regularly taking his meds, and he is doing great. He's one of my best clients. Another guy, I'll give you an example, same situation. I told this guy me and this guy had that conversation of my history before his first appointment. And so it's almost like, it was like a big brother, little brother's relationship with him. He really grew on me, I really grew on him. And he was one of our MAT patients, medical assisted treatment, meaning he was on Suboxone. And the thing that I'm most proud with this guy is that, you know, he picked himself up, we helped him find a place, we helped him get into a program that would we helped him get into a program that helped him find a place. Then he got a place, has a steady job. And then it's funny, like, he disappeared on us for about 3 months. And, you know, I would text his phone, call him. And I was a little bit worried at first because this guy was like a stellar client. So for him to just fall off the face of the earth and not be in touch, it really had me a little bit worried. But again, after about 3 months passed by, I got a call from a strange number. It was him. He had changed his number and forgot to give it to me. But then I asked, like, so why you been in the clinic? Like, you ain't came to pick up your meds or anything. You know, this guy told me he tapered himself off of Suboxone, and now he no longer needs it. It's been over a year, and that guy's still clean, still in the community doing what he's supposed to do, has a great job. He still checks in with me every now and then, and it has absolutely nothing to do with his medical care. It's all about, again, that relationship. We built a relationship, we built a bond, we got these commonalities that can't be broken. And I feel like it's a testament to the structure of this program and the structure of the TCN model, that a client will be in such a great place that they'll taper themselves off of MAT and still want to check in with his CHWs just to say, hey, man, the job you did is still working. I'm still here. I'm still straight. I'm still fighting a good fight. So all in all, I'll sum up this whole talk to those two situations. When you put people in position from the community to help the community, serving the community, they serving the community and the population of people that they have commonalities with, it's like it's nowhere you can't go with that. It's nothing that you can't get through to this population of people. True, we have some ups and downs. We have some good stories. We have some bad stories. I mean, of course, it's all on the individual of what level of care they'll accept and what level of care works for them. But again, you definitely have a better shot when you have a person from the community working in the community. Thank y'all for your time. And I will pass it on to my good friend, Lisa.
Thanks, Tommy. So to build upon what Tommy was sharing, his side, you just heard the anecdote of what that feels like. I often get asked the question of like, but really, what is a CHW doing? Like, how do they spend their time? What are the issues they address? And this paper that was published by our group out of the national expansion work that we did a number of years ago, studied the CHW interactions with over 700 patients who were enrolled, and found that over 80%, close to 80% of them engaged with the CHW. Most of those had multiple interactions, like more than 4. And you'll see here that the social determinants are important. They're mostly housing, transportation, insurance issue, and government benefit issues, along with others, but they're not everything. So it's not just social determinants of health. Our CHWs are also connecting with patients on medication management, their physical and mental health conditions, and just being there for emotional support, like Tommy spoke about. So there's really an art to this. What the TCN CHW is not is a case manager who's sitting behind the desk all the time. And I don't say that to speak negatively of case managers, but what I'm explaining to you is that the work that has to be done for people who are coming home from incarceration is not done entirely behind a desk. It is undoable in that fashion. This work shows. Most of these meetings in this study, most of these encounters happened in the community, in person. And I think the thing to highlight about that is that the TCN model does in some ways push the bounds of what is traditional standard primary care, which is office-based, and really says like, that's just not going to work for this population. And what people want and need is care in the places where they are, whether it's in the halfway house, out in the community, homeless, at the job. There are different places that people need to interact with support from a CHW that's not just office-based. And Tommy gave the anecdote behind that, but this is some of the data that supports that as well. Next slide. And we've studied this even further. So in people who engage with TCN have fewer emergency departments, about half as many emergency department visits. They have fewer preventable hospitalizations. So those are hospitalizations for conditions that you should never really need to be hospitalized before if you got good primary outpatient care. Examples are asthma exacerbations, decompensated congestive heart failure, and pneumonia, where you can treat those things as an outpatient, ideally, if you're well connected to care. And then on moving to the right, on this third box, we've also shown that our program impacts criminal legal system outcomes, specifically people who engage with TCN have fewer probation and parole violations, fewer interactions with probation and parole, and fewer days, almost half as many days incarcerated if they do go back in. And this is a big one when it comes to what our patients care most about. It is cost saving as well, on the order of $2.55 for every dollar invested. Next slide. But the data is important and necessary, and is the evidence, but there are other best practices too. So it has to be done really in a certain way, which is what our Transitions Clinic Network Executive Director, Dr. Shavit, who you heard from, and our whole central office there really spend their time doing, which is facilitating this work for health centers, because it's really transformative. When you think of kind of traditional practice in health centers, this is really transformative care. It is what our CHWs are able to do when they're properly embedded in health systems, is prioritize human relationship, practice cultural humility. An example of that one is sometimes, even though this is what I do with all my time, the CHW will still say to me sometimes, like, you're not hearing him. That's not what this guy's saying. And I'm like, oh my goodness, thank you. Like really trying to help bridge our understanding of each other when it comes to patients and health systems, meeting people where they're at. Somebody, return to substance use after release from incarceration is common. It is dangerous, especially with the poison drug supply, but sometimes people just aren't in a place where they want to prioritize sobriety. That's not where they are. Their recovery is not number one on their mind right then. And the CHW is able still to work with people without needing to see a certain outcome. So sometimes it's just the relationship. It's like, you don't have to come to clinic, but I'll still bring you clothes, and you can still call me when you want help, and you can still let me know when you're disappointed that your daughter's not talking to you, or whatever kind of social stressors you're facing. And then sometimes after a couple months, people come around, or they have an overdose, and then they, their priorities shift. And so the role of the community health worker is really to stick with people who want that relationship when they return home. They advocate tremendously for patients at the individual level, like I've just been mentioning, but really also at the systems level. So we're talking, again, underline and bold, like system transformation. We're talking about, like Dr. Shavit mentioned, changing late policies. Like, that just doesn't work when you're not from a community, or when you haven't been back for years. Like, we can't expect people to be at this certain time and turn them away if they're late. It also means changing the way other providers think too in the health system, specialists, emergency departments, et cetera. And that is done by accompanying patients to their appointments, being on the electronic health record, integrated and able to communicate with specialists, all of that. And it also requires really challenging hierarchy and norms with a lot of community input, often with community advisory boards. And like Dr. Shavit mentioned earlier, avoiding replication of carceral systems. What does that mean in practice? It means not always checking a urine when somebody is on Suboxone, because it's not always going to change your decision. And suddenly somebody sees that you actually trust what they're saying to you, and that their recovery takes many forms, not always, identified through a urine toxicology screen. Certainly they have a role at times, but that's not what underscores our treatment of a person. It also means not reporting back to probation or parole without someone's consent, without their assigned release of information, and them having told us, what do you want me to share back? How much, how little, how can I advocate for you? Next slide. And, in the past 12 years of doing this work, I personally, as a provider and somebody who directs a statewide network of programs, have learned, a ton about what shape this actually takes. I've already shared with you a couple of anecdotes, as has Tommy. But I think, some of the other lessons that I've learned, especially in speaking to programs who aren't quite ready to embed a CHW, is that, there's a lot of downfalls to that. And one of them is that really where a CHW is best positioned for this work specifically in caring for people coming home from prison and in other forms of incarceration is in both being able to be immersed in the community, so like half their time literally in the community, but also connect it to power. So connect it to power within the health system. Just hiring any community health worker into your average community-based organization does not always work, because it's the connection back to the health system and to the power within the health system, which can often help the community health worker leverage their role and most effectively advocate for the patient. What do I mean by that? Which is that, let's say, for example, a person comes home, they have congestive heart failure that was diagnosed while they were incarcerated after they got COVID and were very sick with that and hospitalized. The person might call the community health worker and they start the conversation. I'm out of some meds. I don't know the names of them. The community health worker works to get the list of medications from the DOC. They sit with the patient and they look through all their bottles and say, which of these medicines are you missing? They identify it's the water pill. The person's legs are starting to swell and they're getting uncomfortable, but that CHW, the work doesn't stop there. The way they actually keep this person healthy and out of the hospital is to be able to connect back to the health system and cause action. So it might be, hey, Dr. Puglisi, here's the medicine this person is missing and he needs it prescribed right now. He doesn't look like he's feeling well. And I'm gonna reach out to the nurse and get him scheduled for the nurse to see him tomorrow to just lay eyes on him and see if he needs anything else. So it's not only the ability to be in the community and identify issues when they're just starting to arise and build trust and connection, it's connection to the health system to actually also sometimes, actualize a change in plan or get the person what they need in a timely manner. That's not, for those of you on the call who work in health systems, this is not easily done. But this is the role of the community health worker as well. And I think that's a big lesson that we've learned over the years, is truly embedding them within health systems is where CHWs are most effective. I'll pause there for now and turn it over to James.
Hello, everyone. As Lisa said, I'm James. The TCN manager at Community Medical Centers in Stockton, California, formerly incarcerated. But as everyone said today, hiring the right person for this position is essential to the success of this program. And as an example, before I was hired, the senior community health worker at TCN, Joe Calderon, spoke to the man who is now my boss and said, hey, if you want that program to be successful, you need to hire James Mack. and as I was brought along, it became true. It's not just important is how the person with lived experience is supported, but how that community health worker is supported by the organization and integrated into the healthcare team. For myself, as I said, when I was hired, there was no program like this, and I was kind of given this program and said, hey, we have your back, do what you do. And as I kind of felt around and to see what that was like. I always had somebody with me, representing me and saying, hey, okay, and introducing me to people in our organization, saying, hey, this is James, this is what he does, help him. And so I felt comfortable going to providers and saying, hey, this is what I do. Can I count on you to help me? And sometimes I would get that answer, sure, I'm going to treat your patients just like I treat all my patients. And I had to stop and say, no, I don't want you to treat my patients like you treat all of your patients. These people have been through a lot, and I don't want them to have those experiences repeated. So they need trauma-informed care. They need patient-centered care. So as you know, and it differs from clinic to clinic. The situation is unique, and so now as a supervisor and a former CHW with lived experience of incarceration, I try to reinforce with clinical staff and leadership that having someone patients can relate to on the healthcare team not only results in better outcomes for the patient, it helps us all be better at what we do. Having that CHW in the room, as Lisa talked about, kind of translating for the provider and for the patient, it can make all the difference, because if you're not in that room, there could be misunderstandings, and a lot of times folks coming out of incarceration don't understand how to advocate for themselves when they go in that room. One of the things we try to always do is have our patients write down what they want to talk about with their providers, so that they remember those things. But those are things that eventually it comes down to how the CHW represent themselves. But I try to try to make the process smoother by teaching the people that we hire now that, you know, that they need to be part of that team. And it's about, this is what we're trying to create. Can you change the slide, please? While we're trying to create change for individuals receiving care, or as Lisa and Dr. Shavit said, we're seeking to change what receiving care looks like. We're trying to transform systems. This whole thing, this is about health equity, and people of color are disproportionately impacted by criminal records. Historically, people with criminal records haven't been allowed to work within health systems. So by hiring individuals with lived experience of incarceration, we're planting seeds that'll grow health equity in the community and the communities that our new hires come from. But not only are we reversing some of the harms of mass incarceration, we're actually actively making our communities safer places to live. And I think that's what everybody wants. And so it's when we go out and ask people to partner with us, this is my biggest job, as far as I'm concerned, is to represent what is possible. When I step out there and I start talking to business people, the people in the parole department, they don't know who I am. They don't know that I spent 28 years incarcerated, because I don't look like that. I don't speak like that. But when I do share that with them, the mouth drops open, but possibilities become more visible. The perspective changes, and that's what I really want to create, because I want people to think that if he can do it, maybe those other guys can do it too. Maybe those other women, those other people can do it too. So it's just being that representative. And okay, can you change the slide, please? So one of the things that, some of the things that I would like to recommend is, of course, like it says, ask that question of the person that you're hiring. If they have that history of incarceration, and find out, how that you can help by, if your organization has food pantry available, clothing, they have housing assistance, employment assistance. And one of the great things that we've done here at Community Medical Centers is hire a housing coordinator that works with our patients coming home from incarceration. And it's just, and even though it's really, really hard to find that housing, we have somebody helping. And that alone makes a difference, because a lot of times when we talk to people who return incarceration, that and ask that question, what happened? A lot of times we hear, nobody helped me. And that's what we absolutely do not want. So the things that we do, besides help navigating healthcare, we develop those relationships with those all the reentry providers for groups, food, housing, whatever. We develop those relationships so that we make it easier for our patients to access those services. You kind of have these go-tos for specific resources, and we look at the ways that we can help policy change. For example, like Shira shared earlier, creating these community advisory boards to see what's needed out there and ask those questions first before we jump in. One of the things that I think is huge is, as in San Francisco, the fair chance ordinance, for example, where employers have to consider the mitigating circumstances and the evidence of rehabilitation when somebody has a history of incarceration before they decide just not to hire them. Something like that makes a huge difference, especially when, as you're against that, you're dealing with 44,000 collateral consequences of incarceration. So eliminating any of that, it makes a huge difference. And we change the slide. How to support the employees with lived experience is by one of the things that for me that made a big difference is my organization presented me to the entire organization during COVID. We weren't meeting in person, but we were doing it virtually. So we had a Zoom meeting basically with 600 people involved. And I was presented in there. It was 2 years into the program, and I had the opportunity to thank the people who worked to help our patients and help the program grow. So things like that, and it shows that our community health workers are actually part of that organization. We talk them up. We encourage staff to look for possible candidates for the program, and that we are likely already seeing. Okay, I'm going to hand it off back to Sharon now.
Thanks, James. Can we go back one slide? Thank you so much. Aren't these folks great? I just feel so lucky to be part of this network and work with such fantastic people. I'm going to wrap up because I want to make sure we have time for Q&A. Thank you. I love all the hearts and claps. I know they're amazing. Just really quickly, though, I do want to conclude with, there's some really important changes on the horizon, thinking about addressing the health needs of people impacted by mass incarceration, the growing recognition that these policies do harm in our communities. But the number one piece, and I think Lori Martin raised this early on in the chat, was that these Medicaid 1115 waivers. So California is the first state to get an 1115 waiver approved by CMS, which will allow us to turn Medicaid on 90 days pre-release. So that means that we can provide services to people before they're released from incarceration. They will come out of state prison or jail with their Medicaid in hand and active, and it will allow programs like ours to meet with people pre-release and really engage them into care, to have seamless care into the community. And that it's not just the insurance piece and connecting the systems, but that community health worker engagement, that relationship, the real opportunity to meet with someone before they come out and really engage them into care and overcome these tremendous barriers. And specifically the barrier of, stigma and fear around the care that they may get in the community. So this is huge. Here's a little, just picture of other states that are applying, but I see this as one very promising and prominent policy that everyone should know about as we all move forward in trying to improve the health and well-being of people coming out of incarceration. Next slide. And then I'm just going to lastly wrap up with our last slide here, which is just to, encourage any of you to reach out to me. We are a capacity building organization. What we do is support health systems in transforming what they do to better care for people impacted by the criminal legal system. And so if you're interested in transforming your own system, in really reversing that harm of the stigma of hiring people with criminal records, we work with HR systems. We're very experienced in doing this. We have amazing outcomes to show what happens when you invest in the community and let them lead the work. They know the way, they know what to do. They just need the resources and support. So our organization can help with consultation, program development, capacity building and training, and evaluation and research. So I'm going to leave it at that because I know there's lots of great questions, and feel free to reach out to me or our teams at any point. So with that, I am going to stop talking and let Kelsey lead us in the Q&A.
Thank you so much, everyone. I really appreciate, again, everyone joining and really sharing all those really insightful lessons learned and best practices. We really appreciate it. So now for our Q&A, a lot of great questions that we've received already. And I'm going to share kind of a mix of questions we've received, kind of pre-selected through the pre-registration, and then also some of the ones that are coming in live. So first up, I want to ask if Neil Chaudhary is on, and if so, if you wouldn't mind asking your question out loud. Might be taking us 1 second to unmute you. Okay, you should be unmuted, Neil, if you're on.
Yeah, is this okay? Can you hear me now?
Yep, we can hear you. Thank you.
Oh, yeah. So yeah, I work at a community health center in Boston, and I'm actually a case manager that works on a reentry team at our community health center. So focusing on clients who are releasing into homelessness. And I think something we've really struggled with over the years is retention. So we'll very often see people once or twice when they get out from exiting from incarceration. And this is even after we've gone into the jails and actually met with them a few times before their release. But something we've keep talking about in all of our team meetings of how to keep getting people retained past like the first or second visit to our community health center. And just that's definitely why I attended this session today, which was amazing. And I'm so grateful for all the speakers, is just to learn even more how we can do a better job of retaining patients at our clinic.
Great. I think perhaps Tommy, this would be a great question for you.
Yeah, honestly, that's kind of a tough question, only because with this population of people, it can really be a hit or miss how serious they take their care, how engaged they'll be with the program, so on and so forth. But I think, again, this model that we're talking about, as far as formerly incarcerated people, working with formerly incarcerated people, and same people from the same community working with people in that community, or so on and so forth. I think that kind of helps bridge the gap. I mean, when you have a person like me or like James reiterating the importance of being engaged with the program over and over to them, sometimes that can make the difference. But at the same time, I wouldn't beat myself up over it because they're just so unpredictable, especially in the early stages of their release.
If I could just share on that question, one of the things that works for us is that, of course, that relationship is everything. So when we establish that relationship, we have access. We have better access to them. They're going to call us more. They're more likely to call us than they will anyone else when they need something. Plus, we understand what's going on with them, what the priorities are, and when we do that, we kind of know where to find them. We kind of know where to look for people, and it makes a huge difference. But it's all about that relationship.
Great. Well, thank you, James and Tani. So I'm now going to ask if Dana Flannery is on to ask her question live.
Hello, can you hear me?
Yes, thank you.
Hi, Dana Flannery here from Arizona, and I was fortunate enough to be a part of writing the waiver for Arizona's Medicaid for this. But I think, first of all, I want to thank you all for everything that you do and you're speaking today. And then second, I wanted to ask you, what do you find as the most beneficial, whether it's training or other practices, for primary care staff and other medical staff that are newer to integration and the work of social determinants of health or health-related social needs?
Thank you so much, Dana. And I think this would be a great question for Lisa.
Sure. And Dana, tell me if I'm answering correctly, but if I'm getting to your core question. But I think that there are increasingly ways that addressing social determinants of health are being integrated into electronic health records. And I see that where I practice. But the real connection, like the magic sauce, the special sauce, is the community health worker. Because what traditionally happens is you identify a social determinant in the electronic health worker record, it gets flagged, and then a flyer gets printed out of the electronic health record with resources. But for people coming home who have multiple other competing needs, plus other medical, mental health, or substance use disorders, like that just doesn't cut it. A printed flyer of places where you can go to get food is just totally inadequate. And so I think that the lesson for primary care providers, because I think your question focused on the provider, is around skill sets and working effectively with different team members like community health workers, and understanding their practice potential, and kind of how to help advocate for them on medical teams, and how to help integrate them as well. Because that's really where the meaningful social determinants of health work gets done in my experience. Shira, I don't know if you have anything else to add there.
Thank you so much, Lisa. And now I'm going to ask if Taylor Orioles is on the line to ask her question.
Okay, can you hear me?
Yep, I can hear you. Thank you.
Okay. Yeah, so I do a lot of case management type work and find myself also interacting with other case managers. And it's often, I find myself communicating with the case manager and not the client or member in my case as much. So sometimes information gets lost and it's harder to assess the justice involved member to see what really they're needing. So I guess my question is, what are the main needs that justice involved members are needing support with upon reentry into the community? Like what could I kind of guide the conversation towards a little bit to support them in the best way?
Thank you so much, Taylor. And that seems like a great question for James.
Hey, hi Taylor. So It depends on the person, of course, everybody has different priorities. If even those with chronic health issues, often that's not the number one priority for them. So it really does differ, but those basic things, those Maslow's hierarchy things, food, shelter, food, shelter, and clothing. A job is like, if you can offer that, if you can offer a job, then you might be able to do some other things for you. One of the things I have a program with one of the area supermarkets in Northern California that will hire people that I refer to them who come home from incarceration. And one of the things that when people come and they ask me for a job, I tell them, okay, I'll help you with that, but you have to come see me. I won't recommend anybody that I haven't met. So come to the clinic, get physical, and we can talk. So you use whatever you find out what they need, and you have those resources available, and then you can kind of do other things.
Thank you.
Thank you so much, both.
Hey, can I add one thing really quick?
Go for it.
I would also say, like, be mindful of like your interactions with that person and the relationship you have with the individual. And what I mean by that is I've seen a lot of organizations like drop the ball just off of their client interaction. Like some clients will come to me like, yeah, I was involved in such and such program, and that case manager, he just didn't get it, or the case manager was so nasty to me, I just stopped going. And in the back of my mind, I'm thinking to myself, like, that program actually has some good things for that client, and that client could really be successful if they would have stuck to the program. But unfortunately, they lost that client due to their interaction with that client. So I would just say, be mindful of that. You're dealing with a population of people that has been beat down mentally, treated very inhumane in some situations. And unfortunately, a lot of that inhumane treatment came from the medical side of incarceration. So just be mindful of, the person that you're dealing with and their past traumas.
All right. Thank you so much.
Great. Well, thank you. Thank you, everyone. We have one minute left. I'll try to squeeze in one more quick question here. It'll have to be a brief answer. Apologies. But from the chat, someone asked, do you differentiate between CHWs with lived experience from credentialed peer support? And perhaps as part of that, I think another question is, what type of training do CHWs receive? So Shira, we'll pass that to you.
That's a great question. And I know, different people use different definitions, but I think one of the really important things is that for us, it's the key piece is that lived experience. So whether someone's trained as a community health worker or trained as a peer support specialist, and both of those roles, are appropriate in this work. It really sort of depends on whether you're in the primary care setting versus the behavioral health setting. But that core piece is that lived experience. So for us, that is really the most important piece. And then that the person is trained with specific skills. And in our case, when we're talking about community health workers, we think about C3, which is a project to define what are the core competencies for community health workers and what are those exact skills. I don't have time to go into all of them. I do want to highlight one, though, which is so critical to this work, which is advocacy. The community health workers advocate on behalf of the patients, both in the health system. So they advocate to me as a provider, like sometimes like, hey, Dr. Shivy, you just don't get it. This person needs this now, and here's the reasons why, right? And I then need to listen to the community health worker and support the client, but also more broadly to the system. And we told you there are 44,000 collateral consequences of incarceration that people are up against. And we are healthcare providers, and we directly see those impacts. And if we don't step up and say to our systems locally, regionally, or at the state or federal level, that this is, worsening people's health, those systems will never change. And our programs, I'm really proud of all the work we've done nationally in our programs to transform our own policies to ensure that people's needs are being met. So that advocacy piece is also a really, really important aspect of the work, so that whether they're peer support specialists or community health workers, critical to supporting people in navigating these complex systems that are really, structured to work against them.
Thank you so much for that answer. And thank you again for my speakers, as well as all the participants, for all your wonderful questions. We really appreciate having this conversation with all of you. We're a little past time here, but just to quickly wrap up, for all the participants out there, if anyone's working to develop evidence on what works for caring for adults with complex health and social needs, we welcome you to submit resources and ideas to the Better Care Playbook at our website, which is on the slide. And then finally, again, please fill out the evaluation survey that will pop up on your screen after the webinar. We really value your feedback as we help develop more content. So thank you again, everyone, and I will let you go. Have a wonderful afternoon.
Thank you so much, Kelsey.